This 13-year-old patient was referred to me for endodontic treatment of tooth number 30. As you can see, large decay into the pulp. She had all the signs and symptoms of irreversible pulpitis with acute apical periodontitis. Now take a look at these roots. These were mesials were 25 millimeter long and distal was 24 millimeter long. So today went ahead and IV sedated her and did her root canal, of course, in one appointment. So what we did was cleaned out the decay, rebuild the mesial wall because we need 4 intact pulp chamber walls. 1, 2, 3, 4. Why do we need 4 intact walls? Because we don't want any saliva from the mouth to get inside of the canals while we're working, even though, of course, we use a rubber dam. Secondly, gingival bleeding, if there's gingival bleeding, can carry microorganisms and drop everything into the canals, contaminating the canals. And thirdly is that we need 4 intact walls to contain our sodium hypochlorite. Okay, so definitely when you remove the decay, you rebuild the missing wall or walls before you start the endodontic treatment. Make sure that you rebuild these walls, and when you rebuild them, make sure that they're sealed. What I do is, if I'm suspicious that whether or not they're sealed or not, I fill the pulp chamber with sterile saline and look. If I see that I'm losing volume, then I know that I'm not sealed. The walls are not sealed, and then I try to figure out which area is not sealing properly. Okay, so make sure that your walls are sealed before you initiate the endodontic treatment. I usually use self-bonding flowable composite. Sometimes I use Duotemp. Google Duotemp, all right? And Duotemp is a dual cured IRM, kind of feels and looks like IRM, but it's dual cured, so you can cure it with your curing light. As well as, of course, it cures with time. It takes a few minutes for it to cure by itself, or if you shine curing light on it, it'll make it set so you don't have to wait. And here's the post-op. As you can see, everything went beautifully. Look at these curvatures. 90-degree curvature here, 90-degree curvature here, and look at all of these anastomosis between the mesial canals. 25 millimeters, 24 millimeters. So we went ahead and temporized the tooth and referred the patient back to her dentist for the permanent restoration. Father, of course, she's 13, so father will take her to her dentist for the permanent restoration within the next couple of weeks. This patient was referred to me for endodontic treatment of teeth number 29 and 31. I'll show you number 31 in a second. There is a temporary bridge on these 2 teeth right now. There was pulp exposure on tooth number 29 and tooth number 31, very close to pulp exposure, so the dentist stopped drilling. And this is tooth number 31. And here's the post-op of tooth number 29. Went through the temporary bridge. You can see the shadow of the temporary bridge right there. And take a look here. Tooth number 29, it was necrotic. And take a look here. Look at all of this anatomy. A lateral here, another lateral here, and the canal bifurcates in the apical area, as you can see right there. So much anatomy here. Take a look. Everything went beautifully. So that's tooth number 29, and let me show you tooth number 31. And this is tooth number 31. Take a look. Mesiobuccal, mesiolingual, distal buccal, but look at all of this anastomosis between the 2 canals, the 2 mesial canals. Take a look at all of this. Everything went beautifully. We temporized the tooth and referred the patient back to her dentist for the permanent restoration. And this is another angulation. Again, you can see that we cleaned the space. We cleaned all of this space. This space needs to be cleaned. If you don't clean this space, disinfect it, clean it, disinfect it, then it becomes a space for microorganisms to grow. So we three-dimensionally cleaned the space, and then we were able to three-dimensionally obturate it. As you can see, everything went beautifully. Look at the curvature of the distal canal here. One minute, okay. This patient came to see us for endodontic treatment of tooth number 8. This tooth was traumatized many years ago to the patient. Patient says he used to kickbox, so he had traumatized almost every single tooth in his mouth. And this one is the worst one out of all of them, as you can see. Um, um, a large periapical lucency right here, and take a look clinically. So that's the tooth here. You can see all of his teeth that were traumatized and chipped. And that's the tooth number 8, discolored, and you can see a labial parietal sinus tract associated with it also. So today we went ahead and started and completed the endodontic treatment in one appointment. We knew that we needed to use MTA in this case because we knew that the apical diameter was large, and also the fact that we may have to at some point, maybe down the road, in the future, perform an apicoectomy if we see that the non-surgical treatment today was unsuccessful. So this tooth is now ready for apico, just in case. We'll have the patient come back in a few months to check to see if this periapical lucency is healing, and the labial sinus tract should go away within a couple of weeks. But if we see that the root canal non-surgical treatment is unsuccessful, then now the tooth is ready for an apical because we already put MTA in here. We don't have to retro prep and retrofill anymore. It's already ready to go. So apical would be much faster and easier. So we'll see in a few months.